Good evening, everyone. Welcome to podcast number 11, Pain Consultants USA. Tonight, we're going to talk about neck pain after motor vehicle accidents. So, something that unfortunately is very common. We see pretty commonly in our practice, and a lot of us may have even experienced this at some point or another. So, how you doing, Dr. Bonner?
I'm doing great, thank you. How are you?
Good, good. There's some snow up this way. How's Florida
Ooh,
treating you?
it's a little cold today, just about 70 to 75. So we're all wearing jackets and boots and things. So
Oh, good, good. Yeah, well, I'm glad you're hanging in
yeah,
there. Um, I thought that the plan for tonight's talk will kind of briefly go over what it might look like acutely after an accident and how we might evaluate a patient and treat. And I think the majority of the talk will be addressing those cases where the patients aren't getting better with conservative care. But to start, when you see a patient after a whiplash type injury, which most car accidents are, what are you looking for? How would you kind of go about treating them, whether medically or who would you refer them anywhere right away?
yeah. So we start with, in this case, the history is going to be pretty short. Did you have neck pain before this started or before the accident? And then what happened in the accident? What did you hit? Did you hit your head? Did you hit on the front, hit it on the back? Try to get a mechanism of the injury, how it happened exactly. But there's probably not going to be too much else to say besides kind of where the pain is and then, what makes it worse for them. But you're going to help them figure that out because if you're seeing them pretty quickly, they probably won't even have figured those things out yet. So, is the pain just in your neck? Is it in your neck and up into the back of your head or the top of your head? Or is it in your neck and also radiating into your shoulder or down into your arm? Those would be some things that would maybe lead us to think something a little bit differently. So those would be important things for a patient to think about or note if they're having pain after an accident like that. Um, and then the really important thing I think is um, examining the patient. A lot of patients who end up with maybe really severe pain are going to end up in the emergency department. So we probably don't end up seeing any of those patients in our offices pretty acutely after an accident. And so in those cases, a patient oftentimes will get like a CAT scan of the neck or something to make sure there's no fractures or major issues in the neck. Um, if that's not the case, if it's not really severe pain, I probably wouldn't tend to order an image like that right away. But I would think about ordering in like an X-ray right away. Um, but on the exam, we want to make sure of a few things. We want to first figure out where the pain is, figure out where it's tender, see if that can help us localize where the pain's coming from. Figure out which movements make the pain worse. Is it worse looking up, looking down, turning your head to the side, either way, tilting your head to the side? And then does any of that make the pain radiate in a certain direction? Additionally, as a patient, you also want to make sure you have a full neurologic examination. So, in your cervical spine or your neck, the spinal cord travels through that area. And if your neck is injured, you can certainly have an injury to your spinal cord. And the spinal cord is one of the most vital structures in your body. So, it carries all the nerves from your brain down to your body. And if you have an injury to the spinal cord, uh, you could have things like numbness or tingling in an arm or in a leg or in multiple arms or legs. You could have weakness in your arms or legs. You could have trouble walking. You could have loss of control of your bowel or bladder. Um, and so those would be important signs to let your physician know if you're having some of those symptoms after a motor vehicle accident with some neck pain, and that would be a sign for us to more urgently get a study like a CAT scan or even an MRI of the neck and check on those things. So that's probably the most important thing as a doctor that we're thinking when a patient comes in after a motor vehicle accident is this a critical injury to the neck? And we need to rule that out by discussing it with the patient and by evaluating kind of the neurologic system. So that's the first thing I'm thinking. And then, where would you go from there?
Yeah, I agree with you. As long as there's no real neurologic findings, really stiff neck, some range of motion restrictions, headache, pain going into the scapula area or the shoulder blades, all reasonable. You might even get some shoulder discomfort. It's very common post injury like that. Um, so again, no weakness, no dense numbness in the arm, balance difficulty, or other concerning things. Then I would really start with some conservative care. I mean, majority of these patients with a little bit of time and TLC, they'll get better. So I'll either start. I'll kind of review with the patient. Everybody's got a little preference, but as long as pain's not shooting down the arm, I'm okay with either a little PT or chiropractor. Um, Either of those treatments, I would, especially if it's really acute within a week or two, um, like less is more, right? There's not too many times we recommend a more passive based program, but some hands-on manual therapy, heat or ice, whatever feels better at the time, maybe a little stim, ultrasound, that type of stuff initially might not be bad. If you're in an area that you know of OMT specialists, right? So osteopathic physicians who practice OMM or OMT, this would be a really good role for it as well, because there's a lot of what we call indirect treatment options that don't involve like manipulation of the neck, and could be very useful during these acute situations where everything is kind of in spasm, right? So after whiplash injury, your head goes forward and back. Oftentimes, when the muscles stretch so quickly, they'll go into almost like a involuntary spasm afterwards. And trying to tease out, is it pure muscle versus other things, is difficult initially. So you treat conservatively. In my opinion, the muscle stuff usually gets better with appropriate care within the first 3 months. And if it's lingering, then it might be reasonable and appropriate to kind of do a little more evaluation.
Yeah.
Would you agree with
Yeah,
that?
I mean that all sounds pretty good. I often, after ruling out anything really bad, I tell patients, look, it's just going to take time. Um, it takes a long time to get better from some of these things. And one of the things I often discuss with them is how we can't really see some of these injuries. They're not things that we can visualize. We can't get an X-ray and often see damage to kind of muscles or maybe cartilage within some of the joints. Sometimes we get MRIs or CAT scans. I mean, excluding any major injury to a disc or one of the bones, we don't see a lot of injury to muscles or other small ligaments or connective tissues. We can't visualize that on imaging studies. And so we just kind of perceive these things, and we understand that with time they tend to get better. And with these other kind of other interventions in the meantime, we can help the patient feel better while we're waiting for the tissues to kind of heal themselves. So I often just discuss that with patients so that they know, no matter what we see, there's probably other things that are there that we don't see, but we can kind of infer that those things happen based on what type of injury happened.
Yeah, and sometimes I'll even, and I don't know if it's really been described or not, or it's valid, but say you have pain on both sides of your neck and you're trying to tease things out, we might kind of load one set of joints, or have them bend their head and extend it to one side. And typically, if it's maybe disc or joint, you might think that pain will kind of be worse on the same side. If pain's on the opposite side, sometimes I think, maybe that's more myofascial or muscle related because you're stretching some of the muscles. And if pain's on the same side, well then, and it's not on the opposite side, well, you're shortening the muscle and maybe you're loading some of those other structures. So maybe there is something more to it.
Yeah, I would think the same thing there with that. So.
Yeah, but I mean, you especially initially, you rule out the shoulder, right? Pretty rare, but I've seen a couple of rotator cuff injuries due to arm positioning, depending how high of an impact the accident is. You had mentioned as far as hitting your head. There's a lot of awareness around concussions nowadays. So something too, just asking them, do you remember the injury or the accident? If they don't, well, what's the first thing you remember afterwards? The last thing beforehand is important. This is, when we might start getting into some more mild head injuries, but it's important to find that as well, because that can help to direct some treatment. Some instances, they should maybe even be seen by somebody who specializes in concussion care. But like I had alluded to, I'd say the bulk of the patients that we end up seeing are the patients who don't get better with time, right? Because like you said, most will go to a chiropractor, or most will go to ER. Most will see their family physician after an ER trip, and then everybody has a chiropractor that they know and like, or there's a lot of physical therapy places out there that, and depending on where you are, you might not even need a referral. So there's a lot of kind of initial care that's done before we'll see patients. When I'm seeing them back, or for the first time a few months into this, I'm asking all the same questions that you mentioned. Now that some treatments occurred, I also want to make sure it was the right treatment, right? So just being able to review what records are available, and then talking with the patient. Well, for the last 3 or 4 months, I've gotten ultrasound 10s and a heat pack, and that's it, right? I mean, that's it. And those other 6 people were doing the same thing next to me. So that's terrible, right? I would almost say, well, pretend you didn't get any treatment. We kind of have to start from scratch. But or I've done something, but it kind of aggravated it. Okay, well, that can give us some information. But if my kind of rule of thumb, if we're 3 months into it, symptoms are still going on, you've undergone some appropriate conservative care, that's when I might order an MRI of the neck if feasible. CAT scans, they're tough. In my opinion, in the neck, right, get them in the ER, but they miss a lot of discs, a lot of disc herniations and things like that. So get an MRI, make sure there's not a disc, especially if you are getting some referred pain in the arm. If on exam it doesn't really seem to be muscular, right? So if the muscles don't seem that tight, if there's not too many trigger points on examination where like you might squeeze a muscle and it might send pain up here or down the arm in a distribution where you have pain, well, that's a trigger point. If there's not too many of those, then I'm looking to see, are there clues? I mean, do they have pain radiating between the shoulder blade? Does it go down the arm? That might make me think a disc or a pinched nerve. If pain's in the neck going into the shoulder blade, but maybe not down the arm, sometimes I'll think more disc mediated. We always talk about, and we've talked a lot about, low back issues and disc mediated pain. In the neck, it's not as common, obviously, but it can occur. And then, there's the cervical facet joints, which are, you have them from the base of your skull all the way down to your belt line. In the neck, there are some good studies that have really kind of described the referral patterns of cervical facet mediated pain. And with the whiplash injury, it's not that it's causing arthritis within 3 months, but it can irritate the joints. There's capsules of the joints that actually have pain fibers. They can kind of, from that whiplash injury, kind of be set off and cause some issues. So They're the kind of things that I'm looking at when I'm seeing a patient a few months into injury. Um, Anything else you want to add to
Yeah, no, I
that?
mean that's pretty good. You see someone later on, you definitely start thinking about, okay, what imaging hasn't been done that could be useful. A lot of times that's an MRI, or if the MRI is done, you want to look at it. And then we start getting into, of course, we talked about you talked about some therapy and things. Of course, most patients will try some medications, and we've talked a lot before about kind of types of medications that can be used. Um, is there any ones you would specifically use in this type of patients? I mean, a lot of patients would get
Uh,
an anti-inflammatory, a muscle relaxer, maybe something that's more of a stronger, just opioid pain medication acutely to kind of calm pain down. But what do you like to do?
yeah, I mean, I think anti-inflammatories, as long as you can tolerate it and it's safe, kidneys, heart, GI, I think everybody start there. Muscle relaxers, especially acutely, I like for this
Mm-hmm.
issue. And depending, like if the pain and the muscle tightness, stiffness is keeping you up at night, you might want to try something more like a cyclobenzaprine, which
Yeah.
might actually have some mild sedating effects to it. So it might help you sleep a little. A lot of people get tired on that. Versus if you want something maybe less sedating, if you want to use it during the day, I've been finding myself leaning more towards methylcarbamol or tizanidine
Mm-hmm.
personally.
Yeah.
Um, uh, Muscle relaxers are tough. None of them directly work on the muscles
Mm-hmm.
for the most part.
Yeah.
They all have, they could all make you a little tired. So,
Yeah.
but that would kind of be my rule of thumb. I personally would stay away from opioids, even acutely,
Yeah.
in my opinion.
Yeah.
I'm not a big fan of that. The once they're started, I mean,
Mm-hmm.
you never know what's going to
Yeah.
happen,
Agreed.
especially most of these issues are going to resolve on their own.
Yeah.
I would, I'd rather treat it with non-opioid medication.
Yeah. Sometimes I think it's a hard conversation to, and I've probably said this before, but it's hard conversation to kind of tell a patient, look, you're gonna have to wait a bit. This will get better, but you gotta wait, and you gotta rest. You gotta take it easy on yourself for a little bit. And for some people it's very difficult for them. Some people need to work. They can't miss work. They need the money, and they have a heavy job, or they're doing a lot of manual labor, and so they can't afford to miss time like that. And it's tough when you're trying to balance something like that, where you want to tell someone, look, wait to get for this to get better, but they don't want to wait because they can't afford to wait. So sometimes if someone says, look, I really need something to help me get through, that's when I'll go to a stronger pain medication, just a small supply, and say, look, this is only to be taken when you really absolutely need it. Okay. Otherwise, and a lot of times I also say this should only be taken if you're planning to lay down and rest for the next 3 to 4 hours when you're going to take this. Okay, this shouldn't be taken
Yeah,
as like, I'm going to take this and then I'm going to go do a bunch of work. That's not a good strategy. The opioids block your ability to feel pain. If you take an opioid and then you go do lots of things that are causing more pain but you can't feel it, you're not going to feel it then, but you're going to feel it when the medication wears off. And then you're going to
yeah,
rebound with even more pain than you had before. So, my instructions are take this and go lay down for 2 to 3 hours and get some rest. Okay, that's what it's to be used for. It's not to be used to push through things like that. So, um, I'd say sometimes there's difficult cases where people can't afford to miss time at work or something like that, and I give them something a little bit stronger. But it's usually just like 10 pills or something, and just
yeah,
for
yeah.
when the pain's
Very
really
short
severe.
supply.
Yeah.
I would agree with what you said. I would just put the caveat, um, blocking the pain by going out doing something might make it worse. That's really only an acute pain. It's just to clarify, this would be different than chronic pain issues
Right.
like we've talked about before. But yeah, an acute pain, you you don't want to feel. It's good to feel better, but yeah, you don't want to aggravate it. You do have to give time to rest.
Right.
Um, you know, so we get the imaging, like you said, unless you have pain that's shooting down the arm, it's very rare to see like an acute disc herniation, especially in the neck. I mean, there's not much room in the cervical spine.
Mm-hmm.
Usually we know based on exam what we're going to find on an MRI. We might get lucky once in a while to see inflammation of a facet joint,
Mm-hmm.
but that's very rare, I would say.
Yeah.
Even in truly facet mediated pain, which we'll talk about how we diagnose and treat, it's rare to see any findings on MRI. Some of our older patients, right, who might have underlying arthritis, might have some stenosis, whether in the central canal or where the nerves exit. Sometimes we'll see nerve irritation, so nerve root irritation. In those cases, that nothing new happened and they didn't have symptoms before, but now the injury aggravated uh, the underlying condition. So. Um, that's again kind of important to kind of talk about, mention, identify, so then we could prognosticate recovery. Before we go into treatment, so maybe we'll back up and do you want to, or can you maybe explain or even show a little bit on your hand or in your neck? Like, so in nerve pain, right? We have 8 cervical nerves, and each nerve in the body refers pain to a certain area, right? So if patients are having some pain in the neck, maybe the shoulder blade area, and then into the arm for whatever reason,
Mm-hmm.
what's like, where will they feel pain with possibly what nerve being involved?
So,
Can you review that?
yeah, we tend to think, classically, we think that if it's C5, we think it's kind of in the upper arm, up in this area here. Let me try to get that in the picture. Okay, maybe down here. Not too much involving the hand, and these can vary. So, this, just because we say this, it doesn't mean that you don't have a problem that's a little bit different, but these can certainly vary. And then classically, C6 might go into the thumb and the pointer finger there. C7, I'm not going to put it up by itself, but it tends to shoot into the middle finger. C8 into these and down in this area, and then T1 kind of in the underarm here. But T1, I think would be very rare. I don't think I've ever seen a T1 radiculopathy for patients, meaning like a nerve root injury. So I don't think I've ever seen a T1. We don't see a lot of thoracic radiculopathy or nerve root injury because the thoracic spine tends to be quite a bit more stable than the cervical or lumbar spine, just based on the rib cage being connected to it. It really stabilizes it and prevents the major disc herniations and other problems there. So I don't think I've ever seen a true T1 radiculopathy. Some C8s, but not too many of those. But most commonly you'd probably see C6 and then maybe C5 and C7 are other common ones that we probably see. And then really there's higher cervical nerves, but I don't think we frequently see them, or maybe I under recognize them, but they might cause more pain just up in the neck or in the side of the neck there, and not radiating out into the arm because they don't control any of the sensation or the muscles in the arm.
Yeah, yeah. I mean, I completely agree. C5-6 is the most common. Again, there's a lot of motion that occurs through there. Think about it, you got like a bowling ball on held up by a golf tee almost,
Yeah.
And so it's very vulnerable to these types of injuries.
Some of us have like a
Agreed.
14-pound bowling ball too.
Yeah, I know some people
Yeah,
like
yeah.
that. But yeah, C6, like you said, into the first 2 digits. A lot of those patients will also get some like outside of the elbow type discomfort. And the pain could skip areas too, which is important. And that can sometimes confuse things because a lot of patients might not even have much neck pain, they'll have shoulder blade pain and then some arm discomfort. So, or hand discomfort. So a lot of those patients might actually be treated like a shoulder injury initially
Yeah.
because of the shoulder blade discomfort. But it's very common to have a disc issue. So usually cervical disc will refer pain into the shoulder blade. It's almost like a lumbar disc where everybody has pain over the SI joint area pretty much. Right? So it's just a common referral
Right.
pattern for those discs. I've seen some C4. I would agree it's kind of more up here. It's difficult to know.
Mm-hmm.
Um, uh, yeah, 3, 4. I mean, sometimes you'll even get some like tingling sensation in the side of the jaw.
Yeah. We had a
Uh,
patient who I
some of those
suspected had
patients.
a C3, but I think I ended up leaving whatever kind of rotation or my fellowship training, but he had really severe stenosis or narrowing of the hole of the foramen where that C3 nerve comes out, and he complained of ringing in his ear and pain right in the neck when he turned his head to that direction. So it was like he was
Mhm.
squeezing the nerve and it was giving him this ringing sensation. Um, but we were trying lots of other things because it's just not a common thing that we would see to see a C3 nerve problem. But based on the imaging and all the other kind of procedures that we did, it was kind of one of the only things that was left at that point to really assess. But I never ended up seeing it through for some reason. I wasn't there to see it through. Um, but yeah, definitely that was the
Yeah.
only person I can remember thinking had like a C3 nerve problem.
Mhm. But before we move on to maybe a different kind of issue in the cervical spine, I say we just kind of tackle, well, how would you treat a nerve issue, right? So if it is a pinched nerve, whether from a herniated disc or if you do have some stenosis where the nerves come out, right? In the cervical spine, the actual nerves will come out kind of more obliquely in the neck, kind of coming out in the front. So even if you have pain in the back of the shoulder, um, sometimes we access it from the side here. Um, we talked about the medicines already in previous podcasts. You have gabapentin, pregabalin, some duloxetine. They're probably the most common ones used. Nortriptyline maybe at nighttime. They all potentially have side effects, especially if this is something that's subacute at this point. We have findings on MRI. We'll probably try to treat it through an intervention rather than starting on a long-term medication. Um, so what we're really talking about in these situations would be epidural injections. Right. So the main point I want to get across is there's two ways to do an epidural injection in the neck. There's an interlaminar approach, so coming from the back. This is performed kind of at the base of the neck where you feel that little bump in your neck. Everybody has it, but that's performed kind of at the bottom because that's where it's safe to put that needle in there. Or you could do a transforaminal approach, which would be from the side. This allows us to access levels that are higher up than an interlaminar approach would. And it really is kind of provider preference based on MRI findings, location of pain, pathology, with regards to what type of procedure is done, whether an interlaminar or transforaminal. Would you agree with that?
Yeah, yeah,
What
I
are your
think,
thoughts?
I, you see, different people do it different ways. Um, there's different possible complications associated with each one. Uh, as far as I'm aware, I don't know that we know of any significant difference in the outcomes um, from either one. So, um, yeah, and ideally you'd have a provider who's schooled in both of them so that if you try one or he or she tried one and it didn't work, they could try the other one and see if that one worked for you. But
Mm.
uh, for me, I always try to target as closely to whatever structure I think is causing pain. So I tend to go for the transforaminal approach just because I can put the injection right around the nerve that I think is leading to the patient's symptoms. Or, Yeah, right in the area where the nerve is kind of being injured by disc or other issues there in the foramen. So I would tend to go with that just because of that thinking. But when you deliver the interlaminar, you certainly get, a lot of flow of medication, and, perhaps it can have similar effect without going directly in the area where the transforaminal approach would go to.
Yeah, transforaminal. I would agree. That's kind of my go-to. Can be used partly for diagnostic reasons too, especially if you're trying to figure out where the pain's coming from. If we're 6 months into it, and patients have maybe seen a surgeon at this point, and we're trying to figure out, do you need surgery or not? So transforaminal, I guess the only caveat would be, depending, some people who are really big, thick necks, big shoulders, sometimes it gets tough getting down to like C7 area on transforaminals from a technical standpoint.
Definitely.
I like them a lot for the higher cervical, like the C4 issues. Interlaminar approach, or I should say the transforaminal is still, it's like a sniper approach. Like you said, it's one level medication right there around that nerve as it exits. And if the issue is where the nerve exits the spine, might be more beneficial. In patients who, the big shoulders are like this, we know some people like that. You can't get in deep down there. So coming from the back would be appropriate, the interlaminar approach. Some of my patients who have multi-level findings, especially in the older population who has an unfortunate car accident, and sometimes it is difficult to know where exactly the pain's coming from. They're behaving like it's irritated nerve, but it's kind of more proximal symptoms. Every so often they get some hand stuff. Well, where the heck are you gonna put it if they have findings at like 3 or 4 different spots? So I'll do an interlaminar approach, again, from the back. It's more of a shotgun approach. You can't really control where the medicine spreads all that much, but you're going to get you're going to get spread in different directions. Or if it's bilateral symptoms, sometimes I'll do an interlaminar.
Okay.
The one thing I would caution you with is, if you have an issue high up, so say C4, and your doctor's doing an interlaminar approach just because that's how they were trained or their comfort level, in my opinion, they probably should be using a catheter then to get the medicine to the C4 spot, right? So there's epidural catheters that are made that are easily inserted at the time of the needle placement. You put it up to the spot, you inject the medicine, take everything out. So it's a way of having the interlaminar approach be more specific. Or if you have findings at a couple spots, you can put a catheter up, inject some, pull back, inject some, pull back, inject some. That's done in a lot of patients who, they're not going for surgery. And you just want to try to get them to feel better.
Yeah, so. And I think the other, overall point there for patients is, if you're having neck pain or neck pain radiating into the arm, and you get a procedure and it provides temporary relief or it doesn't work, there are sometimes other types of the procedure that are available that may serve you differently. So if you're not being offered these different types of injections, you may want to seek out someone who can offer you the other types, because it's possible sometimes that one doesn't help and another one does help. And sometimes we can't explain why that happens, but it's good to have more options available for the patient, because, it's just, it's something else that can help them, because this isn't all science. Sometimes this is somewhat of an art. We start where we think we should start, but sometimes we have to kind of divert our path and try other things, and sometimes the other things work. So if you're getting the same injection over and over again and it's not helping you, that's not a good sign. So your provider should be switching to something else if your treatment is not working. All right.
Yeah, I guess, why don't we move on to the cervical facets? I think that would probably be the next most common thing that we see, or one of the common things that we see post motor vehicle accident. Yeah, in all honesty. Right. And the cervical facets also have a referral pattern. You were such a good model. You want to do that again?
I don't know if I can turn around here, but I can pretend like this is the back of my head and my neck.
Okay.
So,
To the best of your ability,
yeah.
yeah.
So, if you're having pain related to the facet joints, which are the small kind of, if you've listened to other podcasts, Dr. Connor described them as like kind of like knuckles. So there's two of them at kind of every level of the spine that connect the consecutive levels. And so one of the most common ones that's injured in a motor vehicle accident, or that then causes pain after motor vehicle accident, is C2 and C3. So the first vertebra is C1, and that's connected to C2 by what's called the atlantoaxial joint, or the C1-2 joint. That's a little bit different than the typical facet joint, but those details aren't like really important for this. But C2-3 is a very commonly injured one, and that one would tend to cause pain kind of in this area of the neck here, if you can see me, sometimes up into the back of the head and over the top of the head too. And that's a common pain pattern that we see. And it's a common one that maybe if a patient goes to someone who's not well versed in these types of headaches or these types of neck pain, they may get diagnosed with some type of headache when the headache is really coming from that joint there. So, and then as you move down joints, C3, 4, you get a little more pain, less so up into the back of the head, but maybe still up into the back of the head and down into the middle of the neck. C4, 5 would just tend to stay in the neck here. C5, 6 goes from the neck and can radiate kind of down into the trapezius muscles here, and even out to like the tip of your shoulder out here. And then C6, 7, that one may be more likely to kind of go down into the kind of middle of your back there near your shoulder blade. And so I find that these are kind of commonly under-recognized pain patterns. A lot of people present with pain in these trapezius muscles here, and a lot of us think, oh, it's your posture, and your muscles are tight because your head's hunched forward and your shoulders are hunched over. But a lot of those patients may be missing out on a diagnosis of some type of facet joint pain in the mid to lower cervical spine. And so that's something that I like to try to keep an eye out for and treat if I see that there.
Yeah, and I had alluded to the trigger points earlier. We classically think trigger points, again, more the muscles themselves. They might stretch, go into spasm, and then form these little tight areas. If you have trigger points and your physician might be treating the trigger points, whether, little injections, dry needling, spray and stretch type techniques, but, you're getting repeated treatment targeting trigger points, but they're not improving. There's been some studies that say, well, when the facet joints are aggravated, whether it's the C5, 6, again, coming out to the shoulder here, or the 6, 7 down between the shoulder blade, you might have more trigger points there. So you treat the facets, and the trigger points get better. Yeah. So, right, the muscle, again, is the secondary, it's the symptom we see. It's not the primary pain generator. Yeah. And again, I would start to think about facets as the cause of pain. A couple months after injury, symptoms not getting better, pain not radiating down the arm. If we have an MRI and the discs look okay, that's when I would start to think more joint. I would agree with you when you have headaches associated with neck pain. The first joint we think of is that high joint up there, C2, 3. Less common, but can occur. Well, I should say C2, 3, right? So like the back of the scalp, like you said, usually doesn't go like to the vertex. That you could see it on me pretty good. But you also have like the two joints above the C2, 3, right? Your atlanto-occipital, which is C1, 2, and then you have the occiput attaching to the atlas. So C0, C1 joint. So less common, but I had a patient last week, persistent pain and headaches mainly after a motor vehicle accident, and their pain was associated more with head rotation. Yeah. So in some of those patients, that C1, 2 joint might be the cause versus going up and down might be, the joint at the base of the skull,
Yeah.
right? So this kind of gets into a range of motion of the joints, right? It's kind of determined by the facet joints, but we know that the highest joint up in the neck does about 50% of flexion and extension. The second joint, that's C1-2, does about 50% of rotation, and then the rest of it's made up from C2 down to C7. Um, so sometimes we'll try to isolate it that way too. So if they have a lot of headaches with the neck pain, I'm thinking those upper cervical uh, facet
Yeah,
joints.
and those headaches could really be anywhere in the head. If you look at pain patterns that have been reported, they can be top of the head, side of the head, the ear, even kind of up into the above the eye or around the eye. And so those pain patterns can be very kind of confusing to in an untrained eye or to even patients who are dealing with some of these issues. So um, it's a good thing to be aware of that if you've had a car accident and you develop some neck pain afterwards and you also have headaches afterwards, a lot of that can sometimes come from the cervical spine, and it's worth the evaluation because there are good treatments available. I wanted to say also, when you're talking about the trigger points in the muscle, a good point there is that, like you said, a lot of times if you treat the source of the trigger point goes away. The other thing is if you've had the trigger point treated multiple times and it won't go away, there's probably a source for it because really there's not great treatments for these problems in the muscles. So we don't have any kind of evidence-based treatment for like an isolated trigger point necessarily. If it keeps coming back, they're just going to keep doing the same thing over and over again. But if you can treat the source of it, which might be one of these joints, then you can make the trigger point go away permanently. And so it's better to kind of rule out the joints as the cause of the trigger point. And if we can't find one of the joints causing it, then so be it. Then you need to keep going forward with the kind of intermittent treatments for the trigger points. But if there's a source for it, we want to try to make that source go away, because that could be way more beneficial than just repeatedly kind of treating the same trigger point over and over again. Does that make sense?
Yeah, and yeah, completely. And sometimes I'll see patients where it's like from here, it's like the entire distribution, right? You're like, well, how the heck can I pick out which facet joint might be aggravated when pain is everywhere? If you tease it out enough, and this would be like a little tip for the patients who are experiencing this pain, just kind of think about this so you can give your physician some accurate information. I kind of draw an imaginary line in the middle of their neck and say, does most of the pain start above or below this line? Right. So a lot of patients, once the neck symptoms, no matter what facet joints are aggravated, whether it's the ones all the way at the bottom that would cause shoulder blade pain, but once things get aggravated, then all these other muscles get tight,
Mm-hmm.
and then they get a
Yeah.
headache no matter what. So if I draw that line, if pain mainly starts below that line, okay, I'm looking down there, and then the headaches might be secondary to the muscles going into spasm. If pain's above that line, vice versa. So just something like, if you listen to your own body as far as, okay, well, pain feels like it's everywhere, but where does it really start? And then do I notice a pattern, a referral pattern, and that kind of thing
And then
could be
the
useful.
other thing, for the patient to know as practitioners, people have studied kind of which ones of these joints tend to be more painful. And so if your pain tends to be more in the upper neck, up into the head, the most likely one is C2-3. If it's more down in the middle to lower neck and radiating down out to the shoulders or something, the most common one is C5-6. And that's kind of, that's generally what I tend to go with is, like you said, is it up above or below that line? If it's above, I tend to lean towards C2-3. If it's below, I tend to lean towards C5-6, and then go from there. And there are algorithms from the Spine Intervention Society to help us kind of sort this out, to say if this one doesn't relieve the pain, go on to the next one. If that one doesn't relieve it, go on to this one, and so forth and so on. So I tend to follow that kind of guideline because it's just helpful and it's systematic. And so as a patient, sometimes it's frustrating if you try an injection or two and it doesn't work, but if you have a practitioner who's following a system and telling you about that system as it goes along and saying, okay, this might not have worked because of this reason, let's try the next one, then it's worth considering to continue with the treatments, because it's sometimes difficult to nail down which joint may be causing the pain. And especially in a patient like with a C12 or a C01 joint problem, that's probably going to be the C01 is going to be the last joint I would go after, because it's very dangerous to put a needle in that area, so if you have,
when done appropriately, it is safe.
It can be safe, exactly. But it's just because of where it's located, it's going to be the last one that I gravitate towards. So unless there's something that's really kind of triggering me, some sign on the MRI where the joint is very inflamed or something, but otherwise, so sometimes you may have to kind of go through a few procedures to figure out what exactly the problem is. But as long as you're not getting repetitive procedures that are the same thing over and over again that aren't helping, then you can, and the procedures are being done with good purpose, then you can continue to do those things. And that's a reasonable thing to do, basically, as a patient, is to undergo multiple procedures to try to figure out where the pain is coming from in the neck.
So I guess I'll kind of share my treatment algorithm for facet-mediated pain, and then jump in whenever if you agree or disagree. So
I disagree.
I knew you would. In younger patients, people that are working, exam seems pretty consistent. They've undergone appropriate treatment. We're thinking it's facet-mediated. If I can isolate a typical referral pattern and I feel pretty confident, I will try one intra-articular injection. So where I'll put the Novocaine and I will like a lidocaine-based medicine in the joint itself, along with a little bit of steroid. I will do that once. The reason I usually only do it once, just for our listeners, is the true way to diagnose and treat facet-mediated pain is through something called medial branch blocks. And that's the diagnostic portion. You do 2 blocks as long as you have 80% relief or more for the certain amount of hours, and you could go on to radiofrequency, which is the true treatment. But that's a 3-step process at minimum. So for some of our individuals who are working and can't take that much time off of work, I will do one joint injection. I tell them I would define a success as 4 to 6 months of relief. If they get that much relief and they're still having some pain when it comes back, I'll do that again. But if we do one joint injection, it doesn't provide enough relief, then I will, or it doesn't really work that well, I will move on to medial branch blocks. Before we go into that, I mean, does that seem reasonable to you?
Oh, yeah, I think that's pretty good. I mean, 4 to 6 months is probably way more than a lot of physicians would say. So I think, it's a nice conservative approach. You don't want to be delivering tons of steroids to patients. So that's a way to keep a limit on it, for sure.
Yeah. I mean, general rule of thumb, we don't like to put steroids in the same area more than 3 times in a year. But again, these joints are tiny. We know it's not the standard of care to put the medicine in the joint, but like we said, it's a art sometimes. If deemed appropriate, we do it. But if it doesn't give you a long-term relief, I wouldn't do it again. Then when we talk about these medial branch blocks, this is where, okay, we have an idea or hypothesis of which joints are involved. Each joint, the reason you know you have pain is because the little nerves send pain signals to the brain. So each joint gets pain signals or innervation from 2 nerves. So typically, I'll treat usually 2 joints at a time. Yeah. So usually two adjoining joints. Try to be as specific as possible, again, based on referral patterns. So that would be 3 nerves that are numbed up or tested. So you come with pain, you numb them up. Again, you can either be laying on your belly, the doctor can come in from the back with the needle, or you can lay on your side and come from the side. When you get off the table, for the next so many hours, at least 4 to 6 hours, we always say, kind of document your pain. When does the pain go down? How much? Percent relief? Are you able to do more with less pain? Those types of things. If it works really well, again, 80% relief or more, then you do it one more time to confirm, because there's a 30% chance of false positive. First time was a fluke. If you have 2 good responses, then we'll often move forward with radiofrequency. Is that what you tell patients as well, or?
Yeah, I think that's pretty in line with what I do as well. So
yeah. Just a caveat: some insurers will allow you to move forward with the radiofrequency if you have 50% relief rather than 80%. Just know the block themselves, the Novocaine medicine, is as good as it can get. So if you're 50-50 during the block, odds are you're not going to notice a lot of good long-term benefit 6 months out from a radiofrequency. Radiofrequencies can be painful for a little bit afterwards. They can cause even like a little bit of sunburn type feel or a little burning type sensation on the skin. I've had some patients where they'll even notice like a little numbness of the skin afterwards. That's all normal. But that being said, you want to make sure it's going to work. So the block should be really good.
But the other thing is that even if the block is really good, sometimes the radio frequency just doesn't work, which can be very frustrating. But that can definitely happen, and you don't know why, but it just doesn't work. And you don't know why. I've had patients where we got great relief with the blocks, did the radio frequency, it didn't work. We tried another block again just to check and be sure. It worked again, and then the radio frequency again, and it didn't work. And sometimes you just don't know why, but there's a certain percentage of people, even with a 100% response to the blocks, to the diagnostic blocks, that just won't respond to the radio frequency treatment. And that's been shown kind of repeatedly in kind of case reports or case control studies. So
I would say that's the most frustrating thing.
Yeah.
As well.
Yeah.
One of the most frustrating, because you get patients to buy in to the protocol because it takes time, right? And then they see how well they do with the blocks. You go through the radio frequency. It's a little painful of a procedure, for some more painful than others, depending on which joint you're treating. Right, that high joint, that C2-3 joint, you can get a pretty nasty kind of sunburn type feeling on the back part of your scalp that can last a few months in some cases. So, your patients have bought in; they're willing to undergo the procedure with the potential risk of that, and then they come back and they're no better. You feel terrible when that happens.
It's tough, I'm not trying to give ourselves credit here, but sometimes we have a tough job because pain is difficult to treat, and we don't have a lot of great curing treatments for a lot of conditions. And this is that's a procedure that can work very well, and then we get really excited to do it, and then it doesn't work, and that's it's frustrating for the patient, it's frustrating for us, and so, we just, for patients out there, we share your frustration sometimes, because sometimes we don't know why the treatment doesn't work when we think it really should work very well.
Yeah. I mean, you think about it, it's just like failure rates of any other surgery.
Sure.
I mean, go to the best surgeon in the world, for a knee, maybe 10% or more might just not take away your pain.
Yeah.
For no good reason.
Yeah.
One of the things I've seen a few times, and I'd be interested to know if you have, where post motor vehicle accident, classic C2-3 distribution, so base of the neck going up into the head, didn't have it before, headaches are bad, we'll do the block for the third occipital nerve, which is the medial branch, or is the nerve that sends pain from the C2-3 joint. And you do the block, pain goes away, doesn't come back.
Yeah.
Have you seen that?
Yeah, I've seen some people too with similar type symptoms, um, that I've just done like an occipital nerve block in the office.
Hmm.
And a couple people, there's a neurologist who sends me some patients for occipital nerve blocks, and um, I'll tend to think it's maybe more likely related to that joint, but I do it because he asked me to do it. And a couple times it's worked extremely well. And, 100% relief of pain, pain never came back.
Hmm.
So, um, I don't know,
Yeah.
you know,
Sometimes I feel like you're just resetting things,
yeah,
like
yeah, I think
the
that could be
nerve.
it. Or even if some of that lidocaine leaks into a muscle or something and, kind of relieves some spasm in a muscle that's squeezing a nerve, maybe that's what does it. I don't know, but
Yeah, yeah.
I
I mean,
consider
you brought
doing
up.
those occipital nerve blocks more frequently because some of these patients were getting such good relief from them here and there.
Yeah, so you bring up another kind of topic that would be unrelated to the facets or the discs or the nerves or the cervical spine. The occipital nerve blocks, right? So the occipital nerve comes off of the C2 nerve, kind of pierces through the muscle in the back, and then it runs up the back of your scalp. Usually, a textbook, it'll go to what we call the vertex or the top of your head. Um, Most times it's unilateral when I think of like true occipital neuralgia.
Hmm.
It's usually like on one side or the other. Um, and yeah, usually I'll do the nerve blocks kind of over the back of the scalp. Is that where you find them
Yeah,
too,
yeah,
or would
exactly,
you?
right there, right. But a lot of
Yeah.
times I find that they still have that kind of upper neck pain, and it's not far apart, but
Mhm.
I definitely, um, I'm more likely to do it now if I palpate that scalp area, and that really aggravates the pain. And
Mhm.
I don't do it
Yeah.
frequently, but that's when I'm kind of more likely to do it, even if
Yeah.
there is significant kind of neck pain a little bit lower down.
Yeah. And I mean, the muscle that nerve does pierce through the muscle
Yeah,
before it comes up and runs on the scalp.
right.
So it's been described to kind of get entrapped in that muscle too after whiplash. Muscle might go into spasm. So
Yeah,
another reason, um, a little different, but yeah.
yeah.
So another thing to keep an eye out if you're having headaches after motor vehicle. I've seen a few people where they'll have pain directly in the center of their spine. Like you touch the bones, which are for our listeners would be the spinous process, like those kind of solid pointy things in your back,
Hmm.
and literally the pain just feels like it's right between those bones.
Yeah,
Um, and I've just done, and we've had the MRI. Doesn't show much.
right.
Now, could there be a component of disc mediated pain there that the MRI doesn't pick up? Sure,
Yeah,
but I've actually done like inner spinous ligament
yeah. That's what I was gonna say when
injections.
you described that. Yeah,
Yeah,
yeah.
and I've actually like when it's directly in between the ligaments like that. So you'll go in with just a little needle, and there's ligaments between the bones,
Hmm.
and sometimes that's painful, kind of with the rapid flexion extension.
Yeah.
So
And that
I've
fits
had
with
some
what we were
decent
talking
success
about.
with that.
Yeah, that fits with what we were talking about earlier with he's just saying that, we can't see all the injuries that happen in these types of accidents, even with MRIs, CAT scans, x-rays, maybe 50 years down the line we'll have a better test that'll show us, oh, this little ligament is injured, but we don't see that. So we have to base it on what the patient tells us and kind of what we see on the examination. And that's a great that's a great example of finding something on the exam that maybe directs you clinically to treat a certain very specific area.
Yeah. Um, you know, very infrequent, but I've seen a couple patients where MRI is good. They have arm pain though, and the neck pain. You treat facet pain, or you treat their facets,
Hmm.
and the arm pain goes away too. Um, so I keep that in mind too. Like if the MRI looks normal and they still have arm pain, usually those patients, I'll get an EMG or a nerve conduction and
Hmm.
or EMG test on. Make sure there's not an irritated nerve somewhere that gets isolated on that test. But if not, sometimes I'll still look at the facet joints. Um,
Yeah. And that's just, again, another example of if you're getting a procedure and it's not working, don't keep getting the same procedure, right? I'll probably repeat this if I didn't say this in another podcast, but what's the definition of insanity? Doing the same thing over and over again and expecting a different result. So, um, you shouldn't, your doctor shouldn't be doing the same procedure if it's not working, and you shouldn't be allowing them to do the same procedure. Okay. So keep that in mind.
um, I think we did a decent job covering the common causes of neck pain, arm pain, or headaches post motor vehicle accident. Anything else jump to mind?
No, I think that's good. I mean, that's the most common stuff that I would see on an everyday basis, definitely.
Yeah.
So,
It,
if you had a
it,
really bad injury, you're going to end up in the emergency department, and if you really need a surgery, it's probably going to be done way before you see one of us. So,
yeah,
um,
and I mean that's a good point, right? So, well, when do you need surgery
hmm
on your neck,
yeah,
right? I mean, the most common type of cervical spine surgery is going to be what they call an anterior cervical decompression and fusion, right? So where they may come in from the front, remove some of that disc that might be sticking out, that's sticking out posteriorly, and then put a little plate in the front of the bones. Um, Again, if you're having progressive weakness, the neurologic findings, well, that's one thing. But again, if it's a disc herniation, but you're mainly having pain, um, and your strength is fine, everything else is fine, I would say don't let somebody scare you into surgery. So
hmm
even I've seen people with huge disc herniations, some pain, you do an injection, pain goes away, disc gets smaller with time, they avoid surgery. So as long as you're neurologically intact, don't be scared into surgery either, because all of these things do have consequences down the road. Um, a little off topic, but when they fuse you from the front, right, you can still get pain from the facet joints in the back,
hmm
and you're going to get accelerated arthritis adjacent segments. So don't let the motor vehicle accident set into motion a bunch of things that occur that you're going to be paying for years down the road. So,
hmm
yeah. For our listeners, I think we're a good resource. If you do have symptoms like this, or you've undergone treatment and you're still having pain and you'd like a second opinion, this is kind of exactly what we're here for. We can review your treatment records. We can tell you honestly if all the appropriate treatment's been done. We could potentially suggest other alternative treatments as well. So, we're a good resource for that type of treatment and issues.
yeah, absolutely.
Okay, buddy. Well, you did good.
Hey, thanks. All right. Have a good night.
So,
See ya.
okay.